What does it mean to be a great diagnostician? It means that you're able to sort through and process the near hurricane-strength quantity of information that you receive while working up a patient, and then arrive at the correct diagnosis, all while simultaneously avoiding cognitive bias like anchoring, premature closure, and confirmation bias. Here are 4 rules that will help you become an exceptional diagnostician. These rules can be applied to any patient problem, and we will think through them today as if someone is presenting with chest pain. The 4 rules are: Rule number 1, describe the syndrome. Rule number 2, characterize the host. Rule number 3, ask, what doesn't fit? And rule number 4, ask, what could kill them? Let's go over each of these individually. The first rule, describe the syndrome. Studies of cognitive load theory and of master clinicians show that exceptional diagnosticians usually sort through and focus on the 5 or so most essential pieces of information. If we focus on the history of chest pain, what are those essential pieces of information? In chest pain, the history is challenging because the quality and location of the pain does not necessarily help clue you into the source of the pain. That is because many causes of chest pain have shared thoracic afferent nerve fibers. So if someone has an esophageal problem versus a cardiac problem versus a pleural problem, these sensations will go through the same afferent nerve fibers, travel to the thalamus, and then the cortex. And it makes our brain incredibly confused as to where the pain is coming from. Despite this challenge in diagnosing the cause of chest pain, there are 2 essential pieces of information from the history: the exacerbating factors and the time course. Exacerbating factors are things like exertion, which often indicates cardiac pain. Pain with swallowing tends to reflect a gastroesophageal etiology of the pain. And reproduction of pain on palpation commonly, but not always, indicates a musculoskeletal cause of the pain. Even better than exacerbating factors, the single best way to describe the syndrome in chest pain is the time course. So in chest pain, I want you to categorize the time course into 3 distinct categories. The first category is the lightning bolt category. It is a hyperacute time course. This means that the pain comes on suddenly and rapidly reaches near maximal intensity. It's like they were struck by a lightning bolt. These are things like tension pneumothorax, aortic dissection, and esophageal spasm. And myocardial infarction falls loosely into this category as it reaches its maximum intensity usually within minutes. The next category is pain that comes on over hours to days. These are diseases that are acute but not sudden, and the pain builds up over hours to days. And the last category is chronic intermittent. These presentations occur over weeks to months and are highly predictable. On this graph icon, the troughs represent no pain, and the peaks represent pain. For example, if someone walks 5 blocks and they say, "Oh, my chest hurts," then they rest and get better, and they walk 5 blocks and say, "Oh, my chest hurts," what do they have? Stable angina. That's right. The same could be said for someone who is obese, drinks alcohol, and gets chest pain predictably after they eat spicy food. That would be consistent with GERD, right? So that wraps up our first rule. In chest pain syndromes, the exacerbating factors and especially time course are essential pieces of information. On to our second rule, characterize the host. What do I mean by this? Well, if you have a patient with infection, an infectious disease doctor will want to know if the host is healthy and immunocompetent or if they are immunocompromised, because the status of their immune system will determine the likelihood of different diseases. In the same way, I want us to expand our thoughts of the term host to not just be pertinent for infections, but rather for any type of disease process. So when considering a patient with chest pain, it is helpful, for example, to quickly consider if they have risk for myocardial infarction or aortic dissection, risks for pulmonary embolism, risks for panic disorder, or if they otherwise seem healthy. We'll review these risk factors briefly. For vasculopathy, the common ones to think of, as you know, are smoking, hypertension, type 2 diabetes, obesity, and also included would be things like ESRD and prior vascular disease like stroke and PAD. Risk factors for clotting also include smoking, but more commonly long travel, immobility, pregnancy, and surgery. And also you might see OCPs and malignancy on your boards and on the wards. Psych risk factors include a history of anxiety, depression, or intense life stressors. So combining Rule 1, describe the syndrome, with Rule 2, characterize the host, that's how we get really good at pattern recognition. The problem with pattern recognition is we cruise in thinking we immediately know what is happening, and then we anchor on a diagnosis too early. Or we have premature closure. We say, oh yeah, this fits the pattern. It's definitely this diagnosis. Case closed. But we can actually miss the diagnosis that way. So these next two rules help us by mitigating diagnostic error. Rule number 3, ask, what doesn't fit? Oftentimes in patient cases, you will recognize that the pieces of the puzzle just don't seem to fall together perfectly. That maybe there's an outlier or two. And asking what doesn't fit in these moments helps you to re-expand your differential diagnosis so that you don't miss the true etiology. Rule number 4, ask what could kill them? This, when you are in the room with the patient who has this sudden onset of chest pain, this is what your patient wants to know. It's what you want to know. And it is paramount you always consider these with your clinical reasoning as carefully as possible. Because missing these leads to an error that often cannot be fixed. So to review, in order to be a great diagnostician, there are 4 rules we should follow when considering a new diagnosis, and we considered these in the context of chest pain. Rule 1 was describe the syndrome. Rule 2, characterize the host. Rule 3, ask what doesn't fit. And Rule 4, ask what could kill them. If you entrain these habits now, it will help you ace your boards, and more importantly, will help you to be exceptional diagnosticians for your patients on the wards.